from Government of Tamil Nadu. I invite Dr. G. Balamurali to give his lecture.
Thank you, Dr. Rajesh Babu. Thank you very much for the invitation, and also I'd like to thank the TANS members, the President, Secretary, and everybody for this great opportunity to showcase some of my work and to discuss some interesting cases. I also thank you for accommodating me first as a speaker, because at 8 o'clock I have to go for a Rotary talk as well. Today, I'm going to talk to you about surgical resection of complex intradural tumors through minimally invasive techniques. So we all know that tubular retractors have now become common use in disc surgeries, decompressions, and also people have slowly expanded the use for intradural work as well. And the most common intradural work that we do is intradural tumors, and also we do for various other intradural pathologies like syringes, tethered cords, and various other things. So there is an abundance of literature available for the use of intradural tumors using retractors and even endoscopes as well in some cases. So the incidence of tumors are about 50% of all the CNS tumors. The treatment is a complete resection of tumor irrespective of the approach. So if you want to have and achieve and complete resection, whether you do open or MIS, it has to be a complete resection. So that is the goal of surgery anyway. So, you know, in the literature, through tubes and endoscopes, many intradural pathologies have been approached, like intradural tumor, extradural tumors, tethered cords, syringopleural shunt, even split cord. There is a few case reports, Chiari decompression, and also, you know, small lipomyelomeningoceles and dural fistulas. Today, we're going to talk specifically about tumors. The principle of tumor removal is, as I said, is accurate location of pathology, assessing the complete anatomy, a complete treatment, total resection, safe treatment without any neurological deficits, maintain stability as well of the spine, especially at the junctions, at the cervicothoracic or the thoracolumbar, and a meticulous dural closure. So if you're not able to achieve any of these, and if you're not confident to achieve any of these, you should not be doing through small tubes or minimally invasive approaches. You could do a conventional approach. So for a conventional approach, either we do a complete laminectomy and a dural resection, which we are all familiar with as neurosurgeons, and we get excellent results. We can also do laminoplasty, as you can see in the other picture, where I use ethibond and sometimes put this back, especially in young children, or at the junctions where you probably are going to expect instability as they grow older. So both these approaches are well documented, and we've used them for decades. The problem is with open, it's familiar, it's safe, good visualization, it's a quick operation, and the outcomes are well known. With minimally invasive, however, there is a learning curve. There's a learning curve. You need to be good hands. You need to have experience with smaller decompressions, discectomies, and then maybe go on to doing more complex intradural. So you can still get very good outcomes. The disadvantages of open approach, we know it's large exposure, longer stay in hospital, iatrogenic injury, and especially in elderly, you know, you can come up with many complications. The advantages with tube, we all know, is blood loss, post-op pain is reduced, shorter stay, you know, less chance of instability, and it has equally good results. If you take all the tumors, intraspinal tumors, the most common of these tumors are the four, which is a schwannoma, neurofibroma, an ependymoma, and astrocytoma. Most common intradural and extramedullary or intramedullary tumors, which we will deal with. And this is what has been reviewed in the literature as well in terms of tubular surgery. So the prognostic indicators of a good outcome is a subtotal or a gross total resection, presentation neurological score, a histopathological type or grade, the age at presentation, what is the learning curve and experience of the surgeon in trying to get a good result, and if whether adjuvant therapy is needed. And also more newer papers have come up with one of the prognostic indicators being whether it's an open or a minimally invasive approach. This is in terms of the long-term outcomes. So the technique is very simple. You use dilators, you use tubes, you use multiple dilators. You can either use a fixed tube of 22 or 26 millimeter, or you can use an expandable tube. So this is the entire set of tubes which is there. The operation setup is very much similar to any other way, but you need to make sure that your assistants and your team also looks at the microscope, because you're already opening through a very small opening, and your assistant needs to see the screen on the TV. So if you have a tumor, through an open approach, you do midline, you do a midline approach, you do lamina, you do an laminectomy, maybe medial facetectomy, and then you go and do a durotomy and remove the tumor. Whereas if you do an MIS, you're going to go all from a unilateral approach. Whereas you have to cross over, undercut and shave the spinous process. You have to open the dura, but all from one side. And so you need to select the site of the tumor based on the side of the pathology, or if it is a midline tumor, you can go from the left-hand side for a right-handed surgeon. So as I said, you can use either a small tube, a fixed tube, where I use for small schwannomas, small meningiomas up to 22 or 26 millimeter ports, or you can go for an expandable where up to 3 levels you can remove this. So some of the tumors that I have removed, which I'm going to share, are a schwannoma, a meningioma, and even an astrocytoma, where I've gone through a dorsolateral sulcus to remove and biopsy a tumor. So I'm going to show you a very simple basic case example, and then we'll go to more complex tumors. A simple example, the 38-year-old male who was under follow-up, and I saw this patient first time in 2013, but he's had serial X-rays, MRI scans, which show there was a gradually growing a schwannoma. But the patient was not very symptomatic, but in 2018, we decided to operate. So this is how a simple a tumor can be operated, where you identify the location. And once you have identified the location, sorry, yeah. So you do an dural opening. So that is how the dura is open. As you can see that the tube is surrounded, the dura is open. I've got heat stitches, and you can see the tumor right in the middle. And then you do an intracapsular decompression of the tumor. The principles are exactly the same once you entered and once you got the tumor outside. So always in a minimally invasive approach, try to debulk the tumor and try not to remove the tumor in one piece. Because when you have open, you have a little bit more access. Closing the dura, people feel it is difficult, but I don't think it is difficult at all. Even through a small, 24 millimeter opening, you can meticulously close the dura. It's just the way that you use the needle will slightly change, and you end up with a small 4 centimeter opening, and the patient goes home the next post-operative day. So this is a very small, 2 centimeter tumor. So we're going to show you a few case series of some more complex neurofibromas at the cervical region, large dumbbell neurofibromas, or in the craniovertebral junction as well. So complex tumors, you need to understand the anatomy better, the location, the size, the neurology, the vascular anatomy around, and also the important other structures, whether it is the CV junction, or whether it is, in the cervical spine where tumor is, engulfing or compressing around the vertebral artery. So here I'm just going to show you a few examples of how you approach to some of these tumors, just around the C1, C2 region. I have not done any tumor as such, which is completely in going into the foramen magnum, but hopefully in future I might be able to do. So we know that the CV junction is very complex. The location, it's a kind of a tiger country where you have abundance of vasculature, and sometimes these are long-standing tumors at C2 level where they take a very long time to even present, and they are calcified, and sometimes they engulf the vertebral artery. So if you want to do an open approach, you may do a far lateral approach. You may want to remove laterally the C1 ring. You may want to remove a part of the condyles, and you have to even sometimes transpose the vertebral artery in order to go laterally. So the same thing can be approached through minimally invasive as well. Rather than going in a far lateral approach, you go in a fairly lateral approach where you're able to do the same things. So the considerations really are, you need to understand anatomy in this region. Case example. So I'm going to show you first a case of an C5 radicular pain and a patient presents with severe myelopathy. And here you can see almost an 90% encroachment of the canal. This patient was a Nuri grade 3. But no significant, he had no deficits. He just had radicular pain. So first thing is you localize. The second is you dock your tube, which is very important. And then after that, you expose and make sure that you have the full extent of the lesion. And here is the case where, there are two components in this. So there's an intra component, and then there is an extradural component that is going outside. So it's a dumbbell-shaped neurofibroma. So the first thing is my tube is pointing towards the medial part, which is the intradural part of the tumor. So I am very slowly, I've opened the dura. You can see that already the foramen is encroached by tumor. So the intradural part, very vascular part. So I'm very slowly working on the tumor. I'm just only seeing the cord right at the end. So in this, you don't see the cord at all. So as I said previously, you have to undercut and shave the spinous process in order to cross to the opposite side. So once you have removed the intradural component of the tumor, the next you do is you make sure that you are completely removed this part of the tumor. You got all hemostasis and leave the dura open. And then you slightly divert and change the position of the tube. So here you can see that the intradural part of the tumor is removed. And then I'm going to change the position of the tube. And I'm going to go to the the foraminal and the extraforaminal part. So after that, here it's very difficult to close the dura because the dura has been completely eroded by the tumor. So I'm just getting a loose closure of the dura. And at the end of the procedure, the entire tumor is out, which is both the intradural component, the foraminal component, and the extraforaminal component. And all of this can be achieved by just opening through a small 24 millimeter port. And this is the post-operative MRI features. A similar case of a 37-year-old presenting with difficulty in walking and myelopathy. The same thing, I'll just show you a few more steps in this. So this is what you do. You get the two levels of the lamina you have exposed. Then you start thinning the bone down. So this is very important that you drill all the way down, you thin the bone, you are able to then just about feel the ligament, remove the ligament by upcuts, and then you have opened the dura. The dural opening again can be done in different ways, but I just use a knife and Penfield dissector because you're opening within a very, very limited space. Though it looks big, in actual space, you only have place for two instruments and a sucker to go in. So you just open the dura. And after the dura is open, you take heat stitches, and you have to be accurately on the tumor. If you are not on the tumor accurately, then you are going to be in a very, very difficult position where you're not going to be able to see the full extent of the tumor. So you have to make sure that you have the top end and the bottom end of the tumor. So if you're not able to do this, then you should abandon the procedure and either go for open, or you should extend your incision and make it bigger, or do whatever it takes to see the entire extent of the tumor. And then the same thing as before, it's an intracapsular decompression, and you're working all the time on the tumor, and you're not actually going on to the cord or putting any pressure on the cord. So here you can see that, you're just using micro dissection all along, and you're getting the tumor all out in one piece. And that's the nerve root that is attached, you can see. So I've just dissected the nerve root, disconnected the nerve, and that's the last part of the tumor that's coming out. So dural closure, many people feel that dural closure, you don't need to do it meticulously. You cannot do it meticulously. But I feel that, you can do a very good dural closure, even with a very small incision. All you need is a little bit of practice, and there's just a learning curve. And you can still, because no matter whether it's a small space, it's a dead space, you still can have an pseudomeningocele if you don't have a good dural closure. So try your best to close the dura, it's very much possible. I do a continuous suture with the 60 proline, and you're able to run this just by changing the position of the needle. rather than the conventional way. We just have the needle that will just lie down around, and the needle will just keep working all the way around, and then you'll be able to still closure. So this is the axis you see at the end of your surgery. If you did an open surgery, you would have caused bilateral approach, whereas this is the only approach that you take when you have a complete tumor excision. So here's a case which is reported in Journal of Neurosurgery as well. Is a 36-year-old a doctor who presented with thalassemia major and had an hematopoietic epidural lesion which was extending to about 7 to 8 levels. So we were wondering how to do this through a minimally invasive approach. So I used both ways, one approach from above and below. So we used a tube to approach the superior part of the tumor and the inferior part of the tumor. But the middle part of the tumor was quite difficult to approach through this way. So eventually, as you can see in this picture, so I was not able to remove the middle part of the tumor by connecting both of these. I could have spent more time and done this, but unfortunately, I found it very difficult. So we had a small remnant of the tumor left back, but fortunately, it was a radiosensitive tumor, and this patient is almost now, 4 to 5 years under follow-up, and the tumor is completely gone. So another case of a 37-year-old male who came in for a health checkup. He was going to the US and was having a health checkup, and they noticed this X-ray which showed an hyperdense lesion. Which was further investigated and showed a very large dumbbell lesion, more of an canalicular and extracanaliclar in the thoracic cavity rather than the intradural component. So he was totally asymptomatic. Unfortunately, he had to have it removed before going to work, according to the embassy rules that they requested. So if this patient, you did an open surgery, you would actually do either a midline incision, or you would take a J-shaped incision or a hockey stick incision, and you would have to do quite a 2 to 3 levels. A very bulky, big guy, 110 kgs weight. You would have done a big operation. So here we tried to approach this through a very small centrolateral approach, a paramedian approach. And you can actually see the thoracic opening is much larger. I involved the thoracic surgeon to come and remove the part. So the tumor was completely disconnected from the intradural and the foraminal component posteriorly. And then the thoracic component was just hanging there to be grabbed by the thoracic surgeon. So again, he did extremely well with 5-year follow-up. Here's a case of an 60-year-old with a severe myelopathy at the C1, C2 level with significant cord compression. And again, this was calcified, as you can see, that there's a vessel that is going through this. So again, did a far lateral approach. And here you can see we've completely removed this tumor through the same methods and principles as we showed. And here you can see that this patient also had a complete C1 arch and C2 was gone. He was actually a very close friend's father. So he was a 68-year-old person, and that was the incision that we removed. A similar tumor pre-op and post-op, which has been removed. So I just wanted to share these cases to say that even complex tumors at the CV junction, large dumbbell lesions in the thoracic spine, cervical spine can be removed. And this is a patient who's typically a patient would help. Imagine, though it was only a 2-level schwannoma, operating in such a heavy patient would involve a large incision, whereas we removed this to a very, very small tubular retractor. Disadvantages of the approach are there is a learning curve, unexpected pathology, especially at the CV junction. You need to know how to manage your vessels, how to close the dura when there is a defect in the dura. And I use different techniques. We use patches, we use bovine patches, we use our synthetic patches. I use taco seal, which is a very good adherent. So these are all the various methods that you could use. I just looked at my own series of patients, similar. This is not a randomized study. This is not an, like for like cases, but I just took similar 2 to 3 level cases, which I would have done both MIS and open, and I just compared them. And I just found that, the duration of surgery was not significantly, but the blood loss, the hospital return to activity was much, much more significant in the MIS group compared to those in the open group. So the literature again supports this. There is literature from C1 all the way up to the sacrum. Plenty of literature is available. At the junctional level, there's significant benefits of avoiding instability, kyphosis, for neck pain and post-operative pain from surgery. I use the needle the other way. So the needle kind of lies around the dura and you slowly keep working. So now I've done more than 150 or so tumors. So I'm very confident to close it very quickly. But yes, I did struggle in the initial phases. It is not easy to close, especially with the fixed small tubes. Extending, I have done it many times. I've seen especially neurofibromas, these kind of tumors, they kind of float around a little bit. So if you're not accurate exactly at that level, you can see half the tumor and you may not see half the tumor. So these are difficult where you have to expand the tube. You have to turn the tube direction on either sides a little bit, and then undercut the lamina and then go. But so now I would say in the last many years, I've been very meticulous in docking the tube accurately on the tumor. So once you do that, you cannot miss it. It is not at all difficult. And I think any neurosurgeon who has done plenty of intradural work with just a little bit of orientation, like with any other minimally invasive endoscope or tube, is just that please do learn these techniques, but start with simple discectomies, decompressions, single level, multiple level, and then go to very small tumors and then slowly build up your practice.
Sir, I have a question. So how do you manage the CSF leaks such a small opening? If at all you're not able to close the dura, what is the percentage of your CSF leak in your series itself around from the 150 patients?
I've had 4 patients who had CSF leak. One of them had immediately, 2 of them had immediately, and 2 of them had slightly delayed, which is within a week or 2. In all of these things, lumbar drain worked. As I said, in the entire series of minimally invasive work, both for tumors or anything, CSF leak management is fairly very simple, because the entire dead space is closed because your muscles close in. You have to close the fascia very nicely. The muscles entirely closes in and you do not have a major problem. I have not operated anybody for a pseudomeningocele or for a symptomatic pseudomeningocele. So CSF leak is not a major problem with any MIS work. But I think that, you should be able to close the dura. I use patches, I use Tissile, I use Tacocele. So if you're not happy with your closure, use any of these things. Lumbar drain probably solve the problem.
Normally, I want to know one more. How many times did you have difficulty in localizing the tumor, correct level?
I'd say 1 or 2 times for osteoid osteomas and things that I've had. So not for intradural tumors, because I think intradural tumors, you cannot go wrong. With all
no, as you said, the tumor can float around also. It may go little at the time of surgery, you may find it at a different level.
No, it probably, if anything, you may see half the tumor and not the entire tumor as you wanted to see. But I've never missed the tumor. I've had difficulties where I do a lot of bony tumors as well, for like an osteoid osteoma, which we have seen, which is in the facet joint itself. So there, sometimes, you find it very difficult to locate. So we use CT scans sometimes preoperatively to locate that.
Thank you.
Thank you.
Okay, if there are no questions, thank you, Dr. Balamurali. If possible,
Thank you, Rajesh.
After your talk there, you please come and join, because we will be completing only after 9 o'clock, I think.
Okay, sir. Thank you.
Thank you, Balam. But today the TNMC observer is Dr. Balaji Gopalan. He is a neurophysician from Chengalpattu. I welcome Dr. Balaji Gopalan, sir. If he is there, welcome Dr. Balaji Gopalan, sir. Now we will go for the second lecture.
Sir, who I can open, sir?
Dr. Viswanathan, sir. So now Naveen.
Yes, sir. 1 minute.
Dr. Viswanathan Krishnasamy, sir, an associate professor and senior consultant neurosurgeon at Sri Ramachandra Institute of Higher Education and Research, Chennai. He obtained his training in neurosurgery at Sri Satya Sai Institute of Higher Medical Sciences, Whitefield, Bangalore. Following this, he has trained in the UK and obtained the fellowship of Royal College of Surgeons in Edinburgh in neurosurgery. Next slide.
So shared, sir. Is it visible? Next slide.
Next slide. Next slide.
That is not visible, sir. 1 second. Shared. Yes, sir.
Subsequently, he was a fellow in functional neurosurgery in the King's College Hospital in London and Walton Center for Neurology in Liverpool, where he subspecialized in deep brain stimulation, surgery for chronic pain, spasticity, and epilepsy surgery. Now I welcome Dr. Viswanathan Srinivasan to give this lecture on introduction of the functional neurosurgery and an overview of the deep brain stimulation. Welcome you, sir.
Thank you, sir. Thank you for those kind words. And I sincerely thank the organizers for giving me an opportunity to present today in the TANS CME. So it will be a talk aimed more at the juniors, the residents. It's an overview of functional neurosurgery, and specifically we'll cover a little in depth about deep brain stimulation. Now, what is functional neurosurgery? The World Health Organization in 1976 defined it as the selective surgical removal or destruction of nerve pathways for the purposes of influencing behavior. And here is Walter Freeman and Watts doing their lobotomies on psychiatric patients. Indeed, when Spiegel and Weisses designed their stereotactic frame, the first indications again were psychosurgery and not movement disorders. Now, the modern accepted definition is that these are surgical interventions designed to alter the physiological activity of the central nervous system. In 1949, René Leriche coined the term functional surgery while dealing with sympathetic neurectomies, and Wertheimer in 1956 published the first book on functional neurosurgery. But it was way back in 1890 that Horsley started removing, motor cortex for athetosis, pioneered epilepsy surgery, Gasserian ganglionectomy, and things like that. And following on, things like pallidotomy were discovered in serendipity when Ashley Cooper in 51 ligated the anterior choroidal artery. It was with the invention of the stereotactic frame that this specialty sort of expanded further, and thalamotomies, pallidotomies all became very common. But in 1968, levodopa was introduced, and following that, the need for surgery was not really felt. But in 1992, Ras Leitinen reintroduced pallidotomy when, especially for patients in whom drug-related side effects were noticed. But this subspecialty of neurosurgery really exploded after Professor Alim Louis Benabid in Grenoble in France described his experience with deep brain stimulation. And now I am here to sort of first cover, as I told you, the gamut of functional neurosurgery, explain the process flow of the deep brain stimulation surgery itself, the steps of surgery, the post-operative programming and follow-up, and some of the evidence base for whatever we do. Functional neurosurgery is not only DBS. It includes lesioning like pallidotomy. It includes, conditions like primary generalized dystonia, for which DBS of the globus pallidus internus is very useful. Focal dystonia, especially things like task-specific dystonia, the musician's cramps, the writer's cramps, those are all very eminently treatable by a thalamotomy of the ventrooralis anterior nucleus. Essential tremor, the VIM nucleus of thalamus, DBS, works really well. For coming to psychiatric indications, for drug-resistant OCD, deep brain stimulation I have performed are targeting the anterior limb of the internal capsule with a distal electrode tip touching the basal nucleus of stria terminalis. For major depression, lesioning operations like cingulotomy and capsulotomy are probably more beneficial than DBS, but DBS is also acceptable. For Tourette syndrome, globus pallidus DBS is very beneficial. Drug-resistant epilepsy, the anterior nucleus of thalamus, there is good evidence that it works in properly selected patients, and centromedian nucleus of thalamus also is another target. The vagal nerve stimulator is an additional modality for treating patients with epilepsy and also has some benefits with depression. Now, the fringe indications that for which DBS has been used are minimally conscious state, addiction problems, and PTSD. Now, coming to pain, for conditions like intractable cancer pain, insertion of intrathecal morphine pumps, and open or percutaneous cordotomies are useful procedures. Intractable neuropathic pain, failed back surgery syndrome, chronic regional pain syndrome all do well with spinal cord stimulation. For drug-resistant migraine, cluster headaches, occipital neuralgia, etc., occipital nerve stimulation has good benefit. And for patients who have pain following brachial plexus avulsion, a dorsal root entry zone lesioning is a useful surgery. Now, coming to spasticity, intrathecal baclofen pump works for all causes of spasticity. In children with spastic paraparesis following cerebral palsy, in addition, selective dorsal rhizotomy works well for children above the age of 5 years. To deep brain stimulation, what is it? It is a high-frequency, pulsatile, monopolar or bipolar electrical stimulation of a stereotactically placed electrode into a target, which is usually gray matter, a nucleus, sometimes white matter, especially in conditions like OCD. This can be programmed externally and the settings changed. How it works, we really don't know, but probably it mimics cellular ablation and not stimulation. However, to name a procedure as deep brain inhibition would not probably be popular, so DBS has stuck on. Are you able to?
Roberts has a tremor.
Are you able to get the audio from this clip?
Mark Roberts has a
Yes,
tremor.
sir.
He's had it since he was a teenager, and it's getting worse.
To actually have the tremor, this is like handcuffs.
So this is a gentleman with severe essential tremor.
Just take the grab out the box.
He is describing how difficult it is
Mark's
to.
tremor is caused by irregular electrical impulses in his brain. 6 years ago, he had to give up his job as a heating engineer. Mark wants to have surgery where doctors at the Walton will implant electrodes in his brain. They'll use a radical technique called deep brain stimulation. He'll be awake during the operation.
He's unable to feed himself
Mark
also.
is about to have one of the most technically demanding operations performed at the Walton. Deep brain stimulation.
It's Mark with a C. Roberts.
Just to tell you about the stages of the operation, tomorrow will be stage 1, which will be with you asleep and sticking about 5 screws on the top of the head and getting some scans for you, MRI and CT scans. So after the operation, we'll need to try and, you need to make sure that the screws don't come out.
Yeah.
On Wednesday, what we do is in the afternoon, take it out to theater. So what we'll do is give you local anesthetic down there. Yeah. So we'll numb the skin, but we'll be aware of whatever's happening.
Yeah.
And we'll hold and put the electrodes down. All right.
Yeah. I just want rid of that.
This has been a buzz of excitement.
He's unable to sign as well, as you can see.
If steps, typical operation has about 10 or 15 different steps. This probably has 10 times the number of steps, and each step is very critical because we're trying to deliver an electrode into an area with dimensions in the millimeters. So every step is important, and every step, if it goes wrong, can wreck the whole operation.
Mark's scalp to drill a hole through the skull, ready for the electrodes.
As making sure that he's got the entry point and the target perfectly lined up.
Target. The team send different currents through the electrode to test what voltage is going to best control Mark's tremor.
Open close as fast as they can. Take your index finger and touch your fingers back as fast as you can. Please with this. Picture.
As you can see, the effect is right there on the table, and we can pick up any side effects as well. But the main important thing is to select the correct patient for this. So which are the right patients? As far as Parkinson's disease is concerned, it should be a patient with idiopathic Parkinson's disease. So secondary Parkinson's, Parkinson's plus, they all do not benefit from this. So one way to check is if levodopa does work for the patient, then DBS will also work. We assess the patient formally with the UPDRS score and admit the patient for a DOPA challenge testing to find out the extent of improvement in the motor score of the UPDRS. We look for any dyskinesias and motor fluctuations, and these and the severe on and off response, which you see, are all indicators of drug-induced side effects. So those are the patients in whom the surgery is very highly indicated. Which are the patients we don't offer surgery? They are the ones with maybe dementia, severe brain atrophy, psychiatric comorbidities like major depression, impulse control disorders, those with severe anesthetic or bleeding risk, and advanced age. There is no real cutoff, but we don't do it for very elderly patients. But more than all these objective criteria, the patient and the family member should have a realistic expectation. They should not expect that the disease itself will be cured, because all we are trying to offer to the patient is improvement in quality of life. So patients with severe axial symptoms, swallowing issues, though the balance issues, those are the ones who probably will not do well with surgery. So this is the process flow. After routine preoperative investigations, the patient undergoes a planning MRI probably a day or two ahead of surgery. That MRI images are captured into the planning station, and then we plan our target. On the day of surgery, the frame is fitted. We take the patient back to, and then the CT is done. The CT images are fused with the pre-op MRI, and then the surgery goes on. Once the electrodes are correctly in place, the patient gets back another CT to check whether it's positioned properly. Patient then goes in for general anesthesia where a battery is inserted. Now this is the planning MRI, where you can see that these two eye-like structures are the red nucleus, and if you draw a line from the anterior limit of this red nucleus, you can see both STNs nicely in this case, and there you find that that probably is the correct target for the subthalamic nucleus. A 3 Tesla MRI is generally preferable, but we can plan reasonably well even with a 1.5 Tesla MRI. So this is fitting the Lexel frame in the patient, giving local anesthesia through that, and then the screws will go in. This is a CRW frame with the indicator box on it prior to the CT. Once the CT and MRI is fused, the planning station would give us the coordinates for the X, Y, and Z, and the ring and the arc. The patient is wheeled back into theater. After sterile prep and drape, the surgery starts. Now here we are assembling the arc of the frame. We choose one side, which is usually the worst side first, and then the other side. The patient needs, generally the patients are elderly, they need to be cooperative. So we start with the worst side, and then if the patient is too tired to cooperate in the best side, that would be a better trade-off. Now, what you see here is the MER holder that is assembled, and then the procedure starts with a incision, and then a burr hole is placed. And then we put in what is called stim locks. So these are stim lock bases. These are plastic bases which are screwed in, so that the final electrode, when it is placed, it can be held in place with the stim lock of the Medtronic. Each company has its own version of the electrode holder. Once the stim lock base is screwed in, the MER electrodes are introduced. Now you can see there are about 5 channels through which the MER can go in. I usually choose a 3-channel recording. And here you can see that this is a classical signature of the subthalamic nucleus. When you hear it, it is as if the raindrops are falling on the roof. It is unmissable. There is a widening of the amplitude, and these are the STN signatures. Now, this is a patient with a midbrain tremor. You can see that the constant force tremor in a young girl. And this is her on the right. During surgery, you can find that the tremors are definitely better. We record both the MER signatures, we record the clinical response, all of that for the patients during surgery in each of the track, and then we choose which track the better recording happens, which track the better clinical response with the least amount of side effects. We choose that to implant the permanent lead. Once the permanent lead is in place, the patient is wheeled back to the CT scanner, and the CT is superimposed to the previously planned MRI to find whether the electrodes are perfectly in position. Then GA is given, and then the cranial leads are connected to the extensions, which are covered and then brought underneath by a tunnel, just like we tunnel for a shunt, and the final battery is placed in an infraclavicular pocket. Patient stays in ICU for about a day or 2. Initial programming just to turn on the device is done, and further programming sessions happen after 2 weeks when the sutures have come out. What is this programming? Basically, each electrode has 4 contacts. We choose the best contact based on trial and error. We try out each contact with the patient available in the outpatients and choose the one with the best clinical response with the least side effect. Usually we start with a monopolar stimulation with a frequency of 130 Hertz and a pulse width of 60. The frequency probably will be higher for patients predominantly with tremor, and the frequency will be lower when we are targeting speech and gait problems. But the typical frequency is 130. What we move up and down is the amplitude on each side. So these are the standard programming. Now there are also complex programming available, like interleaved programming, bipolar stimulation and things like that for patients who are a little more difficult to achieve optimal stimulation. Now, the newer electrodes are also coming in the market, like directional leads, where the stimulation can be more precise, but it would require a lot more work in the outpatient clinic. How safe is this operation? It is extremely safe. The chance of causing major life-threatening issues like major bleeding, risk to life is in the order of less than 0.5%. The main side effects are stimulation-related side effects. That is usually temporary because we can change either the lead, the electrode, the contact through which the stimulation is going, or some of the other settings. Infection is something that needs to be taken care of, which happens in about 2 to 3% of patients, and that both we and the patients are joint partners in it. Because if there is infection, usually it is not a major cerebral abscess or meningitis. Usually it's smoldering infection along the implant site, but it is extremely difficult to treat, and we will more often than not end up with explanting the entire system. Now let's see whether all of this effort to go through with such a long surgery is worth it. Now, this is a result of a meta-analysis depicted, graphically, where various investigators have said that unequivocally surgery is beneficial for Parkinson's disease. Now, this is the same thing, a much more busier slide, but to just focus on things like mobility, activity in daily living, the p-values are low. Bodily discomfort, the p-values are low. And the same is depicted in this as well. Now, this is a graph again showing that there is a 26% improvement in patients with deep brain stimulation therapy as compared to maximal medical treatment. Again, for things like the motor scores, levodopa-induced side effects are the ones that do really well. Now, this is a patient with generalized dystonia. This is an elderly gentleman who's been suffering for decades. This is a DYT1 gene positive generalized dystonia. And the third video, this is the one with about a month or so after surgery. And you can see that sometimes DBS can be life-changing. Thank you, one and all, for patient listening. I'll be happy to take any questions.
Sir,
it was a very nice.
Sir, we will take the questions at the end of the other two talks, sir.
Sure, sir.
We will have all together, sir.
Sure.
Shooter sudada yenna.
Sir, adu time ayirum, sir. Mottam kettikalam discuss panikalam, sir. Naveen?
Sir, yes, sir.
Sir,
Next speaker, sir.
Next is Dr. Tanga Tirupati Rajan, sir. Dr. Tanga Tirupati Rajan is the consultant neurosurgeon from the Sri Venkateswara Med City. Past experience in Sri Ramchandra Medical College, Savitha Medical College and Hospital, Ghent University, Belgium. Area of expertise, pediatric and endoscopic neurosurgery. I welcome Dr. Tanga Tirupati Rajan, sir, to give his lecture on update in the management of craniosynostosis. Presently, he is a professor and HOD of the Department of Neurosurgery, Sagittal Medical College Hospital, Chennai.
Can you hear me?
Yes, sir.
Yeah, I'll start the presentation.
Slideshow.
Slideshow. Yep. Yeah. First of all, good evening. And I'm really fortunate for the TANS to invite me to give this talk. I'll make it very concise and precise and will not take a lot of your time. Just a small self-introduction. I am Dr. Tanga Tirupati Rajan. I've been consultant neurosurgeon. At present, I am in Venkateswara Med City. Previously, I was the head of department in Savitha Medical College Hospital. So we'll go to the presentation. So first of all, a disclaimer, it's an update, not a class. So I'm not going to give you all the full details of what is craniosynostosis, house management. Just I'm going to talk about what's the latest update on craniosynostosis in the last decade. I'm just going to concentrate on that. So first of all, to be precise and concise, these are the questions I'm going to answer. I'm not going to be in a class format, this, so and so and all. What is craniosynostosis? Has there been any change in the definition? What is this cause and genetics? What are the things that we have learned in the last decade? What are the literature that's come out? and what's the latest in the treatment, and what's the change in the time of treatment. Are there any change in the way when to operate, and what are the modes of treatment? Any new methods have come up, or what are the advantages and disadvantages that have come in the literature, and complications, any new methods of managing the complication. So this is just the basic starting. So craniosynostosis, this part I'll just skip through. All of us know it's just a premature closure of one or more of the cranial walls and the various types of craniosynostosis. So we have the anterior plagocephaly, posterior plagocephaly, brachycephaly, scalpocephaly, trigonocephaly, and the whole the one which I cannot pronounce, where everything is fused back. I don't know whether I pronounced it correctly. So this is a normal timing of closures of all the sutures. So this is all for the postgraduates. You can just go through all textbooks will give you this. So now distribution. See, the most common suture to undergo synostosis is sagittal synostosis, followed by coronal synostosis. And the syndromic ones are pretty rare. So they constitute only about 5 to 15% of this thing. And among the coronal synostosis, the unilateral one is more common than the bilateral one. So etiology, this is all typical textbook stuff. So the exact etiology is still not known, but the risk factors of multiple studies have shown that the advanced maternal age, uterine malformations, especially bicornuate uterus, maternal smoking, male sex, fertility treatment, and especially from our side, neurosurgery side, valproate, warfarin, these drugs are associated during the perinatal period is associated with higher risk of craniosynostosis. And about the theories of craniosynostosis, there's a total presentation. You have two theories, above down and below up theory. So basically, the initial theory suggested that the pathology was within the sutures themselves and the pathological sutures which fused and then caused the defect of restricted skull growth. But the later, the more accepted theory is it's a skull-based problem which is manifested in the sutures. So now we'll go to the talk proper. First is the genetics, what we have learned in the last 1 decade. In 1993, Jab et al. Were the first people to bring out the genetic origin of craniosynostosis in their paper, where they identify the MSX2 gene in Boston type craniosynostosis. From that time, it has exploded. Now, every craniosynostosis, there is a genetic study, from the suture tissue to the blood to the everything is studied now. So these are the 5 genes that are most popular, most focused in craniosynostosis. And the first one is the most important one, Fibroblast growth factor receptor genes. This gene, I think, contributes to more than 90% of the craniosynostosis. So now we go, Fibroblast growth factor receptor 2 gene is associated with all these syndromes, the common syndromes what we know, which are associated with craniosynostosis, Apert, Luzon, Pfeiffer's, Jackson-Weiss, and Brennet bone disease. And the most other important thing I like to highlight is that Fibroblast growth 3 gene is associated with non-syndromic craniosynostosis, the unilateral unisutural stenosis. So if you want to go through all this update, there's a very good review paper by Goose J et al. As a genetic update of craniosynostosis. I think it covers up to 2018. All the studies, they've just done a very nice meta-analysis and given the very concise information in that. Now, coming to what is the new in treatment in the last decade. See, first of all, why we have to operate craniosynostosis? Only 2 things. One is the restricted cranial volume, and the second thing is a cosmetic result. These are the only 2 indications to operate in a craniosynostosis. So there is no question in a syndromic or a multi-sutural craniosynostosis. All of them have to undergo surgery, because once more than one suture is involved, there is a raised ICP chance of 85% around. This is what the studies tell over the last few decades. So there is no question of not operating on them. There will be raised ICP features in most 85% of the multi-sutural stenosis. So we have to operate. There is no question. But if it's a single suture craniosynostosis, why we have to operate? Only 14% of them have raised ICP in a single, even in a single suture craniosynostosis, even if it's small minor suture like a lambdoid suture, the chance of getting a raised ICP is 14% around. So why we have to operate in the rest 85%? You can find it. So that's mainly a cosmetic one. But now there are a lot of literature which comes up, even if there is a single cranial stenosis, the brain under the stairs, a pathological suture is not normal. There is a redistribution of neural function under the pathological suture, even if there is no raised ICP or even if there's no volume loss. Even if the other part of the sutures compensate and grow extra, even though the volume is not reduced, there is redistribution of neural function, especially in coronal suture. If the ipsilateral like coronal suture, the neural functions are redistributed to some other part of the brain. There is a very good study about it, but unfortunately I couldn't get the full text of the study. but the very good, interesting literature is coming out. But the other part of the side of the story is, even if we correct the cranial synostosis of the pathological suture, the the neural function doesn't return or normalizes to back to the thing. It remains the same. So the whole question is why we have to do in a single suture cranial synostosis. The most important is cosmetic outcome. We grossly underestimate the cosmetic outcome in a single suture cranial synostosis. This is a progressive cosmetic disfigurement. It's not just a static disfigurement of the skull. A single suture craniosynostosis over a child's growth, it descends and causes disfigurement of the face also. It's just not cranial, it's mid-face. Then later it will go up to the inferior part of the face. So the whole face undergoes disfigurement, and it has a very negative effect on the psychology and development of the child. Psychologically. So there are a lot of studies which comes now, which said the psychological developmental problem in a craniosynostosis as bad as a neurological impairment. So that's why I think we should operate most of the single suture craniosynostosis. So neural impairment is questioned, but cosmetic correction is absolutely indicated because it plays a very big role in the psychological development of the child. So next question is when to do surgery, whether early or late. Late, now it's been given up. I think it's all cases have to be operated by 1 year. That's what the latest literature says. 3 to 6 months for endoscopic surgery and by 6 to 8 months for open surgery. This is the consensus at present with all the literature I've done. And in my experience also, 6 to 8 months is the ideal period for open correction because it is a major surgery. It takes quite a bit of time. And blood loss in a young child is the most deterministic thing regarding the outcome of the surgery for complications, not as a cosmetic, for complications. We have to minimize the blood loss to the least, avoid transfusion, and managing the post-op period is first 48 hours is the most critical part of this surgery. So I would prefer as a offhand recommendation, not a recommendation, a suggestion I'll tell, for open surgery 6 to 8 months, or a child should be at least 6 kg. From my experience of operating a few cases, 6 kg child at least will have some amount of, you have a reserve of blood loss to take. No later than 1 year, because by the time the damage is done, because the brain triples its volume in the first year. After that, the growth slowed down. So basically, you have to give the maximum space to the brain in the first year, because that's the time when it triples in volume. And all the literature says a lot of people tell early surgery, more complication, no. Complications are same in early and late surgery. Late surgery is more difficult to correct, more longer time, it will know more bigger osteotomies, and the correction is not optimal. The endoscopic correction is are the people who are proposing to go before 6 months. So all the endoscopic people who do endoscopic correction and put the helmet on for 2 years, they propose it before 6 months and by 3 months. Now a lot of papers are coming by 3 months, because for them the helmet does most of the work. They do the suturectomy only. They just remove a strip of sutures, that's all. And the full correction is done by the helmet. So the earlier you put the helmet on, the better the results. So only problem with early surgery going 3 months or more is there is a small risk of restenosis, because bone can grow faster if you remove earlier. But it's a very small risk of less than, I think, 5%. But the numbers are very small to even come under. Only other thing is, in syndromic cases, there are a lot of other things to consider rather than just the skull. Patient can have cardiac anomalies, renal anomalies, the airway might not be adequate, or has a problem, short tongue, thick tongue, palate split. So all these things have to be considered in syndromic cases. So now regarding sagittal synostosis, strip craniotomy is total cranial vault remodeling. Strip craniotomy means endoscopic approach. Total cranial vault remodeling is the open approach. So what is the difference? The literature says in the last 1 year, it's been an amazing study done by the Synostosis Research Group, a multi-center study. They studied more than 207 patients, compared people who have undergone endoscopic strip craniotomy and with the total vault remodeling. They told that they found that there is no much difference in the mean volume that is achieved after 2 years. Volume gain, cephalic index. So it is almost the same. It all depends on when you see the patient and what is the expert in the local hospital, the expertise which is available. So you don't have to do endoscopic just because somebody else is. Your results are good with total cranial vault remodeling, you go ahead and do that if your complications are less. Then metopic suture. here the conventional surgery is much superior than endoscopic repair. So this is what the correction of the face and the morphometric outcomes of forehead, eyebrow, orbit, all these things are much better with open correction, because most of the time here we have to do a fronto-orbital advancement, which is not possible with your metopic. The fronto-orbital plate advancement is the most important thing in metopic suture correction. So this is what was told in neurosurgery focus this paper. So in metopic suture, open correction is much better. So now in surgery, what is the newer development? I think this Nature 2000. See, this is very strange that this paper appeared in Nature and not in any of the neurosurgery, because nowadays the craniosynostosis is not a domain of neurosurgeons anymore. Plastic surgeons, facial-maxillary surgeons, even sometimes these people have all come into, and most of the papers nowadays are coming in plastic surgery, oromaxillofacial surgery regarding craniosynostosis rather than neurosurgery. So in this thing in Nature, I think the whole list of surgeons were involved, from neurosurgeons to some 15 neurosurgeons were involved. In this, they did a 3D printing, neuronavigation combined approach, individualized approach for each patient. They calculated millimeters, did a preoperative CT scan, did a 3D modeling, and then all three of them sat together and did a workflow pattern where they before surgery they printed a specific implant, template for each patient, and then did the surgery. And this was changed the correction from subjective to objective. Before, if you do a craniosynostosis surgery, when I was in Ghent along with Professor Bart, I think he was a referral center for I think Belgium and eastern part of Europe for all craniosynostosis. He used to do 3 or 4 cases a week. Believe me, but in the 3-4 months I spent with him, he did some around 30-40 cases, which is unbelievable. The amount of volume he does. So it was all, but he had good results, but it was subjective, which he has accumulated over a year of 10-15 years of experience he has done and accumulated, and he was able to give that result. Because he used to tell, okay, this case, if you advance 2 centimeters, will be enough. In this case, if you give some 3 centimeter expansion here, it will be enough. But everything was in his subjective sense, but he had so much experience. But we cannot, everybody can't gain that amount of experience. You have to be in center like that. So this change the perspective from subjective to objective. Objectively, we can know we have to advance 2 centimeters this side. We have to retract, cut the bone 3 centimeters here to get a correction of this much degree. So this changed the thing from subjective to objective. So I'm going to focus on this only. So we have done around 5 to 6 cases like this, 3D printed remodeling with templates and with workflow pattern, and the results are amazing. My first 3 cases was like a traditional open, and my next subsequent 6 cases were with this. I think the difference in cosmetic outcome is a sea change. And I will not present a complex syndromic one. We have done 3 cases like that, but I think those things will anyway everybody will see. But even in the mild unilateral coronal suture stenosis, how the results varies, we can see with this. So this is a case study. We did this case around 3 years back. This was the first case of us with the 3D printed modeling. So a 6 months female child, unilateral coronal stenosis, non-syndromic. We done the gene study, and you can see it's a typical face. We have a typical C-shaped deformity in the nose, bossing depression on the affected side, bossing on the contralateral side, and this is the 3D printed model of the child. You can see the coronal stenosis here, and the bossing here, and you can see the orbital discrepancy, wide palpable fissure on the affected side. This is a typical stenosis of a unilateral coronal. And this is what we do is we take the normal side and superimpose on the affected side and create a normative skull derivative. So this is how the normal skull should have been looked for the child if there was no craniosynostosis. So we make this model first, and then we make the template. You take the fronto-orbital plate from the normative derivative and superimpose on the pathological skull. So now we get the template to how the fronto-orbital base, this base will go up to the half of the orbital roof. So you have to remove up to the half of the orbital roof, everything just in front of the cribriform plate, the whole roof will go. We'll make the template for it. See, amount of error correction we have to make, everything from centimeters, we'll calculate. So the virtual band superimposition is done. Next step. See, this thing will sit. I told you, as usual, it's a team play. I didn't do this alone. This is a disclaimer. I had a facial-maxillary surgeon with me who's very good at computers, and he did it on his own in his computer using an Osteo 3D model software. And we had another fellow from I had, from Netherlands, who also helped us with this. So this is the template we made. So we made a 3D printed template. So this is a template which will guide us surgery, how to do the correction. So this is the planning model we did. We sat in together for almost 2 hours. It took us to calculate all the centimeters to get the correct correction. Osteotomy is how to do, where to do the osteotomy. We calculated it and it took almost 2 hours for us. So this is the skull model we made, and this is the intraoperative picture. These are the two supraorbital ridge that is exposed, and this is the before osteotomy. We mark all the osteotomies. This dark line is all the osteotomies we mark. So now this is we have removed the front orbital ridge bandu, and you can see how the thing is there. And this is the frontal plate, we have frontal bone unit we have removed. And see, this is the template, and this is the front orbital bandu we have removed, and we are making it both. We are using the artery to mold the front orbital bandu to the template, to fix to the template, so that it becomes, we make small cuts with the drill, so that it becomes more malleable. And this is why you have to operate around 6 months. The malleability stays. Otherwise, it usually breaks. If you operate after 1 year, the bone will be stiff, it will break, it will not mold. So can you see how accurate? Sorry. Can you see how accurate the pre-op 3D printing and the intra-op model correlates? So this is the pre-op printing we did, and this is the intra-op. You can see how, what was this in a template, with correction template. This was the bandu we removed. So what we make small cuts and correct it so that it fits with the bandu. So this is after correction. This is the before correction. This is an ACon. This is the fontanelle. This is both eyes. This is before the craniotomy. This is after the correction. Can you see this thing is fully corrected to a proper semicircular one? And this is the frontal coronal suture, that pathological one that was removed. So this is the orientation here, a little bit confusing. See the previous the skull which I put down. This is for the guidance. So this is how the patient. This was pre-op. You can see the orbital roof. This is the cuts we have planned. See the skull. This much we are removing. This much we are advancing from here to here. So this is after the advancement. You are seeing from the side how much we have centimeters advanced calculated. Okay, how much centimeters we have advanced, how much correction angle we required, forward angle, even this thing, and everything we are able to achieve satisfactorily. And this is after closure. You can see the pre-op picture. This is the affected side, and this is the immediate post-op picture. The correction is immediately visible. So this is the workflow pattern we adopted. It's exactly from that paper only. So first you do a pre-op CT, virtual 3D modeling, virtual surgical planning. We cut down the design because of the cost. This was done totally free for the patient with a grant from the hospital. So we couldn't do print at the full. That printing design is very expensive. It costs around 50 to 60,000. So we cut down the cost by making only the bandu, the frontal part we calculated in the craniotomy. So we didn't print this part. We just printed the orbital bandu part. So this is the child after 2 months follow-up. You can see this is a pre-op. The correction is very good. This is the two. We can see the nose. Everything is corrected from the eye. So the most important thing I learned is surgery is a team sport. So this is what the craniofacial team in that paper comprised of. So we almost had, I think, 7 or 8 of them in the list. We didn't have everybody, but we were able to manage with that. So the complication, blood loss is the most important complication. The child cannot even take 30-40 ml blood loss. So it will be very, very stingy and take very small, meticulous. Even opening the skin will take half an hour because 1 drop of blood is also very important. A 6-month-old child with 6 kg. The latest thing tells that tranexamic acid may reduce the need for transfusion. There are 2-3 papers regarding craniosynostosis and use of this drug, and they tell that it significantly reduces the need for transfusion. The most important thing is a post-op pediatric intensivist. Do not do the case if you don't have a good post-op pediatric intensivist. Okay, that neurosurgeon is also not needed, but this post-op pediatric intensivist is needed. The first 48 hours is the most important to manage. Managing the electrolyte imbalance, the blood BP fluctuations, hypotension is the most difficult thing in a 6-month-old child after a 6 or 8 hours of surgery. Child will be intubated for the first 24 hours. Usually we don't extubate. So managing that period is the most critical part. And the most common complication is CSF complication. Make very good sure that the dura is intact. Otherwise, you'll end up with a pseudomeningocele, which will spoil all your correct. So this thing. So this is what I like to stress. Early post-operative follow-up craniosynostosis surgery. The most important thing is the availability of a good post-op intensivist, pediatric intensivist. He has to monitor all your metabolic and dynamic factors and keep the child stable. So the take-home message is craniosynostosis surgery is recommended. Literature, there's no question of not doing surgery unless patient opts for it and opts for a deformity. Time is around 6 months you operate. You need a team. It's not a solo sport. Excellent cosmetic results can be obtained with a 3D design and navigation. Post-op care is the most important part to concentrate. So this is the OT team. After the first case we did, we have everybody from the plastic surgeon, oromaxillary surgeon, pediatric intensivist, anesthetist, pediatric anesthetist. This was after the surgery when child was shifted. So this is what I like today. Thank you. I hopefully I kept it short. And this is a child after 4 months when the child sent a photo from the house. So it was nice to see. This was the first case we did in 3D print. Subsequently, we've done 5 to 6 cases, even syndromic ones. And I actually presented the first syndromic one we did with 3D printing in 2018, I think, in TANS before the corona in Mahabalipuram. Not in TANS, in TANS Mahabalipuram I presented. Unfortunately, that time not much attendance was there. Hopefully now at least 50-60 people are seeing. So let's see. Thank you. Any questions?
We will have the question sessions later, sir.
Okay, thank you.
Now we will have the last speaker. Naveen, please. Sir, you stop.
Sir, kindly stop sharing, sir.
Okay, just a minute.
Yes, sir.
Yeah, stop.
The last speaker is Dr. Suresh Babu Tirmal. He is presently the Associate Professor, Department of Neurosurgery, Madras Medical College. He is going to give a talk on visual pathway gliomas.
Doctor, you can share, doctor.
Next slide, please. So this is a diagram of optic pathway, visual pathway for the postgraduates. So starting from the retina up to the optic radiations. So what happens at the various level of the lesion? What will the field defect is depicted clearly. Next slide, please. So this is another schematic diagram for optic pathway. Next slide, please. So optic pathway gliomas, they can be divided into associated with neurofibromatosis 1 or a sporadic optic pathway gliomas. Here it is the classic optic pathway gliomas. They are mostly associated with neurofibromatosis 1. The incidence of neurofibromatosis in optic pathway gliomas has a wide range. It varies from 10% to 70%. In neurofibromatosis, please, previously. So in neurofibromatosis 1, what happens? That's a signal activation of the RAS pathway through inactivation of the neurofibrin 1. That is nothing but a tumor suppressor gene that is well known to the PGs that leads to the tumor cell proliferation. Next slide, please. So what are the features of neurofibromatosis 1? There will be more than 6 capillary spots, axillary freckling, iris nodules, optic nerve glioma, more than 2 neurofibromas or plexiform neurofibromas, sphenoid ring dysplasia or thinning of bones,
and any first degree relatives can be positive for any of these features. And there are many associated fibers features also for NF1. Next. So what is sporadic optic pathway gliomas? As I said, in the classical optic pathway gliomas, there will be a chromosome 17 mutation will be there. Whereas in sporadic optic pathway gliomas, there will be a duplication of the BRAF kinase domain. So leading to a BRAF KIWA 1549 fusion gene. So what happens? There will be subsequent mitogen activated protein kinase pathway activation. So though these tumors have a low grade histology, their management can be challenging because of its limited surgical intervention, and the spread can be aggressive. Hence, early diagnosis is very important for sporadic optic pathway gliomas. Next slide. The sporadic tumors, there can be present as a mass in the optic chiasm, or there can be exophytic mass, and in some patients there can be cystic areas. The cystic tumors are more common in sporadic tumors, which is very unlikely in a classical NF1 tumors. And these sporadic tumors may extend beyond the region of the optic pathway. They can frequently involve the hypothalamus too. Next slide, please. So in this sporadic optic pathway gliomas, what happens? They usually arise from the astrocyte proliferation in the optic pathway in a phenomenon called as arachnoidal hyperplasia. So these astrocytes extends to the layers, various layers of the optic tract, and they invade the subarachnoid space, and they lead for tumor cell proliferation. Because of this, they can go significantly and they can cause an early mass effects. Subsequently, they lead to vision changes. So there is astrocyte proliferation, arachnoid hyperplasia. All these leads going for aggressive growth of these sporadic optic pathway gliomas. Next slide, please. So what is the classification for this optic pathway gliomas? These tumors are commonly classified using the Dodge classification system. Stage 1 is called as, it's involved only the optic nerves alone. Stage 2, chiasm involved. And stage 3, hypothalamic involvement or adjacent structures. So it's based on the Dodge classification system. Yes, next slide, please. So the common symptoms, majority of the patients will have visual disturbances, loss of vision, more than 70%. And proptosis. When the proptosis happens, if there is the optic nerve involvement within the orbit, these patients will have proptosis. Whereas if it is an intracanalicular or intracranial, the proptosis chances are very less. And some patients can present with nystagmus, and some person with hormonal deficits from hypothalamic involvement. In some patients, because of the growth, they can obstruct the CSF pathway, they can produce symptoms of hydrocephalus. And growth is more invasive in the sporadic when compared to NF1 associated optic pathway gliomas. Next slide, please. So, how to identify these tumors? First, they come with the symptoms of visual disturbances. Then the imaging. Nowadays, we are doing the imaging. Previously, used to do CT. CT, what shows? It shows a diffuse enlargement of the optic nerves. These lesions will be more of isodense. Sometimes calcification can be seen within the nerves. But fine details of the spread of glioma are very hard to appreciate on CT. And further, in CT, the exposure to radiation is more. So nowadays, we started performing MRI with and without contrast of the brain as well as orbits. Here, there is one more important called as ocular coherence tomography, OCT. That is mainly for assessing the thickness of the retinal fiber layers. What layer? The peripapillary retinal fiber layers plays a vital role in determining the disease progression. If the nerve gets thin, they are more prone for worse prognosis. So ocular coherence tomography plays the recent days, they are giving emphasis to ocular coherence tomography. Next slide, please. So in MRI, what happens? In T1 imaging, the glioma appears iso-intense related to the optic nerve. And there is a clear appearance of the outline and size of the mass. In T2 image, the mass appears hyperintense. And it shows the indication of surrounding invasion. So optic pathway gliomas can be found at different locations. And NF1 tumors frequently involve the optic nerve with a circumferential enlargement of the nerve with elongation and kinking. Next slide, please. Next slide, please. So pathologically, what is the WHO classification? There are 4 grades: grade 1, grade 2, grade 3, grade 4. Grade 1 is pilocytic astrocytomas. So these pilocytic astrocytomas, the main histological features are Rosenthal fibers and eosinophilic inclusion bodies. And nowadays we are giving emphasis to IHC, immunohistochemistry markers. So in pilocytic astrocytomas, GFAP and transcription factor positive for oligo2 are important. Then come to grade 2. What is grade 2? Grade 2 is pylomyxoid or fibrillary astrocytomas. There are more aggressive tumors, and here also IH is GFAP and vimentin will be positive, whereas cyanotophysin, EMI, and chromocranins will be negative. Grade 3 is anaplastic, and grade 4 is glioblastomas. This grade 2, grade 3, grade 4 have worst prognosis. Next slide. So here on the left side, you can see the eosinophilic inclusion bodies. On the right side, within the circle, you can see the Rosenthal fibers. So these are the 2 characteristic features for a pilocytic astrocytomas, which forms a major part of the optic pathway gliomas. Optic gliomas are majority of cases are low-grade gliomas. So these 2, these Rosenthal fibers and cytoplasmic inclusion bodies, are important histological characteristic features. Next slide, please. So how these patients are managed? Management of patients. Mainly, they observe the patients. How long? Till the patient produces symptoms or worsening of symptoms. So observation plays a major role for optic pathway gliomas, because there's a recognized phenomenon of spontaneous regression of optic pathway gliomas in NF1 associated tumors. But in few patients, there may be progression or worsening of vision. So for such patients, they can go for chemotherapy, and then they can intervene with surgery, then radiation. So when we surgically intervene, generally intervention is recommended when if there is any visual or neurological symptoms. Prior to the advent of modern imaging, what they used to do? They used to do debulking surgery. Debulking surgery was frequently performed, but these aggressive interventions have since been reconsidered due to the risk of damage to the parenchymal and surrounding vascular structures near the optic tracts. Next slide, please. So chemotherapy. So because of the surgical intervention causing some new neurological deficits, first they observe, then they give emphasis to chemotherapy. Chemotherapy has been established as the mainstay of treatment using a combination chemotherapy called with carboplatin and vincristine. They call it as a Packer regimen. The first line of drug is carboplatin and vincristine. Sometimes they can use thioguanine, procarbazine, lomustine, and vincristine regimen also. So the first line of drug is carboplatin and vincristine. Next slide, please. Next slide. Yeah. So then comes the role of radiotherapy. Radiotherapy has also been used for the management of these tumors. Now we are giving importance to stereotactic radiosurgeries, stereotactic radiotherapies, gamma knife, and proton beam therapy. So for the benefit of PGs, SRS means in multiple axes, in different axes, with a single point, they give radiation that is called a single stereotactic radiosurgery. Whereas in stereotactic radiotherapy, in fractionated doses, they will be giving. Gamma knife using cobalt, they are giving radiation. Now using photons, they are using proton beam therapy. So recently they are using all these radiotherapeutic measures for the regression of the tumor. Next slide, please. So surgical role. As I said earlier, first they go for debulking. Then if there is the obstruction in the CSF pathway causing hydrocephalus, they thought of doing CSF diversion. In some patients for sporadic tumors, they can have cyst formation will be there in the lesion. In such cases, they will do a cyst aspiration and they can insert Omeya reservoir so that they can periodically aspirate the cyst. If the mass is producing a mass effect. So they used to do debulking also at sometimes. But if sometimes the resection is feasible without any new neurological deficits, some centers they are doing total resection also. But it should be feasible without any new neurological deficits. Next slide, please. Now, in the modern era, they are giving more emphasis to immunotherapy. Why immunotherapy? Immunotherapy is important because they are highly specific and they have a long-lasting effect. They have decreased toxicity and side effect. What this long-lasting effect? Drug holidays, they say as drug holidays. How long can stop the drug? What will happen? Like that, this immunotherapy having a long-lasting effect. So the rebound growth, according to the recent study, they say that the rebound growth is being reduced if you use immunotherapy. For the sake of immunotherapy, the biopsy has played a vital role nowadays. Why? Because this biopsy only helps us to know the tumor markers as well as the biological markers, biological growth of these tumors. Based on this, they can use various drugs called defrabanib, vemurafenib. So all these drugs can be used for immunotherapy. And certain drugs called as checkpoint inhibitors. What checkpoint inhibitors? In our system, immune system, there are some tumor suppressor genes. And certain chemicals will inhibit this tumor suppressor and they cause this tumor growth. So certain checkpoint inhibitors also being developed like CTLA4 and PD1. And recently they are using bevacizumab. It's as we know, that is anti-vascular endothelial growth factors. And as I said earlier, in the tumor markers, mitogen activated kinase pathway, MEK1/2, these inhibitors, selumetinib, they are also being used for immunotherapy. So the biopsy plays a vital role nowadays to know the tumor markers. Because they are highly specific, they have long-lasting effect. And there is decreased toxicity and side effects when compared to other chemotherapeutic agents, as well as a surgery or a radiotherapy. Next slide, please. So outcome. What's the outcome? Overall, the long-term outcome for patients with sporadic optic pathway gliomas are variable. What they say is 70% of the patients have persistent long-term visual loss despite the treatment. So visual loss is persistent in sporadic, whereas they say in classical optic pathway gliomas, the visual loss is not getting worsened. Even the visual loss getting worsened, but overall the survival rate is high, ranging from 90 to 98%. So this requires a continuous ophthalmological follow-up and MRI surveillance. These two remain important for the patients to monitor the progression of the disease. Next slide, please. So how to plan of management? So as you know, optic pathway glioma is a complex pathology and patient treatment should be individualized. Where possible, decisions should be made with expert multidisciplinary consensus. So treatment decisions should also consider the age, neurofibromatosis status, tumor location, visual, endocrine, cognitive functions, and is there is previous therapy, and last we have taken account of the patient wishes also. Next slide, please. Next slide. Next slide. As we said, there is a debulking and revision in case of any obstruction in the CSF pathway. Next. Until recently, a radiology diagnosis was sufficient in most cases and remains the case on the background of NF1. However, with the advent of biologically targeted therapy, as I said, the immunotherapies, so biopsy is a must. Now they are considering the biopsy is a must for optic pathway gliomas. Next slide, please. That is the surgical resection. There is a mass effect. And the extent of resection depends on the tumor location and the existing neurological deficit. As I said earlier, we should not create any new neurological deficits if you attempt for a surgery. Next slide, please. So total resection is considered where is it possible. In selected cases where a cyst is causing mass effect, then placement of a Oman reservoir for drainage may be appropriate. Next slide, please. Next slide. So as I said, it requires a multidisciplinary approach. Neurosurgeon, neuro-oncologist, radiation oncologist, pediatrician, ophthalmologist, neuropsychologist, endocrinologist, and as well as we require a geneticists who are more in genetic scientists also plays a vital role for this multidisciplinary approach. Next slide, please. So what are the questions in the surgical management of optic pathway gliomas? How to predict which patients have particular course and who may require surgery? Because for majority of the patients, the tumor growth is stable. And some patients are responsive to chemotherapy. So how to select which patients have to undergo surgery? Then, how surgery alters the natural history? Which case will benefit from surgical interventions? Then, which surgical approach offers the most benefit? What is the optimal timing of a given surgery? How long to wait? What factors determine after surgery? What factors will determine or predict the surgical outcome? And which emerging development can improve the surgical outcome? So these are all the questions in surgical management of optic pathway remaining unanswered. Next slide, please. So the take-home message is there is no radiological or symptomatological correlation because the growth may be bigger in a radiological investigations, whereas the patient's symptoms will be less. So there is no clear-cut correlation between radiological and symptomatology. Second point, the patient requires periodical observations and ophthalmological evaluations. Some patients require every 6 months or annually MRI to be done, not CT because of exposure, but they insist on ocular coherence tomography for this retinal fiber thickness. And the more posterior the growth in the pathway, that is posterior to the path, the worse will be the prognosis. If the optic pathway gliomas occurs in adults, they are all high-grade gliomas and they have a worse prognosis. And as I said, chemotherapy plays a vital role. The first-line drugs are carboplatin and vincristine. And biopsy is mandatory for tumor markers and molecular biology. And various surgical roles, as we said, biopsy, debulking, CSF diversion, and cyst aspiration. And if possible, if you can do a total removal of the tumor also. And there are certain questions remain unanswered. So these are the take-home messages for optic pathway gliomas. Next slide, please. Thank you. Then a small presentation. Next slide, please. Next slide.
1 second, sir. I'm opening.
Yeah.
So for the benefit, I muted all. While speaking, kindly unmute yourself, sir.
Now it is the time for the
Yes, sir. Posted, sir. Sir, kindly unmute yourself, sir. Doctor, kindly unmute yourself, doctor. Doctor, your voice is not audible. Kindly unmute yourself, doctor.
No, why I put this slide?
No, doctor. Doctor has one more presentation. Doctor, kindly unmute yourself, doctor. So sir asked to put this presentation also. That's why I put, and the sir is not line. Hello, doctor.
Sir, can you hear me?
Yes, doctor. Yes, doctor. Voice is audible.
Yes, sir. You put the next slide, sir. Yes. So So recently, 3 weeks back, we operated on case, a 7-year-old female child, right-handed, studying 2nd standard. She had complaints of difficulty in seeing objects on the left side for 6 months and headache for 6 months. That is the main complaint. Difficulty in seeing on left side and headache for 6 months. Next slide, please. The patient was apparently asymptomatic 1 year ago after she had bumping into doors and objects on left side, which was left unattended. Her sister also noticed her finding difficulty in finding objects on the left side. So it was progressing, it is worsening. So they attended our hospital. And there was a complete loss of vision on the left eye. Next slide, please. And she also had complaints of a headache for 6 months, insidious, intermittent. It's not more of a ICP type of headache. 1 to 2 episodes per week and holocranial. Next slide, please. Next slide. Other things are normal. Next slide. Next slide. Other than the second cranial nerve, next slide. Other things are normal. Higher mental function, sensory motor system, everything is normal. Next slide, please. Next slide. There is no any markers of NF1, sir. Next slide. So next slide. Next slide, next slide. You put the next slide. Next slide, next slide. So here, the second, previous slide. So in the second now, the right side vision is 6/36, and left side only hand movements. Color vision is normal on the right eye, whereas the left eye cannot be assessed. And the field of vision on the right side, temporal loss of vision. On the left eye, we could not assess. This is the fundus normal on the right side, and the left is the pale disc. Pupils 3 mm reacting to right on the right side, left side is graded on RAP. Okay. Other things are normal, sir. Next slide, sir. Go to the MRI, sir. Next slide, 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 next slide. Oh. Can you enlarge it? Next slide. Next slide. Next slide. Yeah, this one. So this is the MRI picture of the child. So we could not so the growth extends to the left optic nerve as well as the chiasm. The chiasm could not be separately identified. That is edema of the chiasm. Next slide. And this is the axial view. Next slide. So the child does not have any endocrine disturbances, no hypothalamic disturbances. Other than the second nerve involvement, the child does not have any symptoms. Next slide, sir. So the child was next slide. So the child was taken for transnasal endoscopic biopsy for the next slide. Next slide. The Jurassic. Next slide. Next slide. Next slide. Next slide. So the biopsy is taken, sir. Next slide, sir. So the biopsy is taken. Next slide. The pathology came as we have covered the flap. Next slide. So the low-grade glioma, pilocytic astrocytoma. Next slide. As we discussed, the cytoplasmic inclusion bodies as well as the Rosenthal fibers. Next slide. And we have done a IHC markers where the GFAP is positive, sir. Next slide. Next slide. Okay. Yes. So now we are planning the child for the discussion the tumor board, how to proceed further. Chemotherapy, radiotherapy, or like that. The child is waiting for the tumor board. So just a 3 weeks being operated only for information. Thank you, sir. Thank you. Thank you, sir.
Now we can have the first question.
One second, sir. 1 second, sir. Posting, sir.
All the pages, please answer the questions in the chat box so that we will be able to select the winners immediately one by one. In between, we will be asking some questions. The first question. First question is how to access the intradural intramedullary tumors with an unilateral approach. Okay, this is the first question. Okay, now we will have the discussions. Those who have any questions, please can ask the question to the speakers. Sir Viswanathan sir, what is the exact cost of the treatment for the deep brain stimulation? It's happening now, sir, there in Chennai.
Yes, sir. So the depends on the implant that is used. So the cost varies as per the type of implants. Broadly, the implants are either non-rechargeable or rechargeable. Non-rechargeable is lower cost. The implant cost is about 7.5 to 8 lakhs. Rechargeable implant cost is about 10 to 12 lakhs, irrespective of the company. There are basically three major companies that produce the implant: Medtronic, Boston Scientific, and Abbott. There is also a Chinese implant available. Now, the non-rechargeable implant, the life of the battery is about 3 to 5 years, depending on the amount of current that goes through. The rechargeable lasts at least 12 to 15 years. Sometimes Boston Scientific says it lasts 25 years. So for that increased extra about 5 lakhs or so, you will get a much longer lasting effect.
So actually, why we are not able to reduce the prices of the things, sir?
Because the battery technology is extremely complex. See, the cardiac pacemakers are very small, but the amount of current that is required to be delivered to the heart is extremely less. Whereas the brain, which itself is electrical tissue, requires a higher amount of current. So that intellectual property, the miniaturization, microelectronics, these are the three things that matter. So the Western countries, whoever have the IP, they have done well. China has come in, and there are at least 2 or 3 Chinese companies that have come in, and the technology is growing forwards. For example, previously it was only the electrode. Now the electrode itself, you can direct where the current can go. You can sit and do the programming across the world. The patient can be anywhere. Through Wi-Fi, you can do the programming. So the technology is expanding as well. So the cost, instead of coming down, is actually going higher than that.
In our country, people are not at all trying to do it, sir.
No, the government of India has a Department of Biotechnology, which has given some grants and some. They gave out 3 major projects. One was an indigenous cochlear implant, which has seen the light of day. Indigenous ICP monitor and DBS implants have not seen the light of day. The projects have been awarded to some and nothing has come out of it.
Dr. Vishwanathan, is a nice presentation.
Thank you, sir.
And I just want to know, for the Parkinson's, what is the age limit you set to the oldest? What is any age limit you have?
No, we don't have a prescribed age limit, but when the age crosses, say, 80 or so, we are very cautious, because see, the one contraindication is absence of significant atrophy and dementia. So after the DBS itself does not worsen the dementia, but when the dementia accelerates, the patient will associate that the DBS caused the worsening in the patient's dementia. So we don't touch patients who are generally more than 80 unless they are a good 80-year-old, completely no other comorbidities, really well functioning except for the Parkinson's disease. Those are the patients where we may reconsider, but typically we don't touch patients greater than 80.
What about the younger patients? Do you have any of the
young onset PD? It's a very good indication. We have done about around 40 years old or so. Pediatric also, some say, I don't have personal experience, but pediatric DBS for Parkinson's also has been done. In the center that I worked in the UK, one of the consultants' exclusive focus was pediatric DBS, but for dystonia, where they used to do even small children as young as 2 years, 3 years old, sometimes for some of the genetic conditions causing generalized dystonia.
They probably will be putting on the rechargeable ones.
Yes.
Otherwise, you need to keep changing it. It's very difficult.
For dystonia, the frequency requirement and the pulse width requirements are very high. So the battery drains out fast. The battery will run out in 1 year. For OCD, which I have done also, we have recommended only rechargeable implants because we are there stimulating the white matter tracts. So the amplitude requirement is very high and the pulse width is very high. So for those, the rechargeable implants are definitely recommended. Sir.
Thank you.
We will go for the second question, sir. Deep brain stimulation is useful for the following indication: dystonia, essential tremor, obsessive compulsive disorder, all of the above. This sir is given a very easy question actually. That's why they have put it like
I
that.
have to check if all were asleep present on the call.
Sir, Vishwanathan sir, how many cases actually you are doing per week, sir? Actually,
we don't do this per week. We talk of in a year about anywhere between 10 to 15 cases is typically what we do, sir. We have not come to the stage to do per week 2 or 3 conditions. Hopefully someday we will
sir,
reach.
which are the other centers you are doing there, sir, in Chennai?
In Chennai, I do it in Ramchandra and a few other places as well. Other institutes which do that are Apollo and Varela Hospital, MGM, all of these places they do, sir.
Sir, then regarding the craniosynostosis, sir.
Yes, sir.
Sir, how actually you have not put your statistics, sir, actually. Just briefly, you can tell, sir.
Actually, like what sir told, Vishwanathan sir told, it's not seen in months. So far, you operated around 9 cases, sir, from 2015. It's very
actually, for my experience, we have in Ganga Hospital from 2010 we have done 3-4 cases, sir. Actually, all the 3 cases we have done well, sir. Actually, in 2010, 11, 12, in the beginning we had it. After that, we are not getting more cases, sir. And we have used this observable the screws and all those things we have put it, sir. How you are fixing up the this one, sir?
Yes, we also try to use the absorbable, but some cases are not affordable. So there's a technique called buttress technique, where we can avoid using the absorbable. There's a very good paper from UK regarding the using of buttress technique and avoiding the absorbable plates, because they are the major cost for the fact, even for them, not for us. Even in UK, absorbable plates constitute 60% of the cost of surgery.
Yes, sir.
So they also wanted to cut down that. So they started using a technique called buttress technique to fix the frontoorbital plate from going back. Main risk is it will fall back. Once you put the skin will be very tight. Once you correct it and advance the frontoorbital plate and the frontal plates, the skin will be a bit tight to close. So it will push back the plate. So that's why we need the absorbable plates to hold it in place for the first 3 months before it should not go back. So they have a technique called buttress technique. I think it's a bit needs some pictures to explain how to do that technique. But it's a very good technique. We have done it in 2 cases where the patients are not affordable. And regarding the number of patients, we usually get 1 in every 3 months, 1 patient. And usually most of them, we have a grant in our previous hospital I was working. We had a grant from 2-3 international organizations, and we had an association with the central government RBSK scheme, that Rashtra Sevak Sangh scheme, where the central government used to refer us cases from Nepal, West Bengal, Orissa, but only condition we have to do it for free. So somehow we used to get the grant and do it. When the grant allows, we used to use the absorbable plate. When the grant didn't come, we used to use the buttress technique. So 3 cases we have done with the conventional technique, and the rest 6 cases we have used the navigated 3D modeling. We will give very good results with the even with the open technique, the results were good. But once you see this, especially when they send the 2 or 3 year photos, it's very rewarding and it's very nice.
Regarding this anterior plagiocephaly, I think it's a very challenging proposition. How do you remodel this? One side it will be flattened, the frontal bone will be flattened. How do you reconstruct? What I do is I rotate the flap. I take the frontal bone.
The flap.
Yeah, interchange
the flap. You rotate. Traditional teaching, a lot of these things there. But once you see the 3D remodel, I also first 3 cases we interchange. We also, like I already previously worked with Dr. Bart in Belgium. He has a very nice technique of remodeling the same without interchanging. He has a rough calculation in his mind. Because imagine doing cases in 3 months. The volume he has, he is a referral center there in full of Eastern Belgium, Netherlands, Holland, Sweden, everywhere he is the reference. Every case will come to him. So every week he operates. He had taught me some rough techniques, how much cut to make everything. So I assisted with around 20 to 30 cases with him. So that by that way, we were able to achieve good results without just the cut. But once the 3D modeling came, we were able to plan the cuts, how much to cut, how much curvature to correct. So even if you correct the curvature and you can fix it also with this plate, absorbable plate, the curvature. So this thing makes a huge difference. Actually, after 6 months, the patient will look absolutely normal. There'll be no evidence of surgery except the coronal scar.
Yeah.
So that is, I think, will be the success of surgery when there is no evidence of surgery.
Sir, what is the role of molding helmets in your patients? Do you prescribe it post-operatively or in any anterior single suture?
No, sir. Only helmet, literature-wise, could benefit only in superior sagittal sinus, sagittal synostosis. And after doing the endoscopic suturectomy or wide local suturectomy, they will put the helmet to do the remodeling. And it is a very tedious process. I have been in a center where they done also. It's a 2 years fully the child has to wear the helmet. And it should be done early, before 6 months, ideally at 3 months. Because the later you do, the skull doesn't remodel that much well. So that helmet is very tedious, and the results are good for only for isolated sagittal sinus, sagittal suture synostosis. It's not good for literature. It's not good for metopic. It's not that good. But I don't have experience. I have not used in any patient.
I will put the third question. What is the advantage of this incision over a conventional incision?
And also, what is the name of this incision? That will also be a good question.
What is the name of the incision?
We have been using this incision in the last few cases, and it found that it is actually advantageous.
Okay. We are waiting for the answers.
I want to ask Suresh Babu. Suresh, are you still online?
Yes, sir. Yes, sir.
Yeah, it was a nice presentation. I think you have done a nice, severe, hard work, homework, collecting the data about optic pathway glioma. Is there? I have seen a few cases where there is exophatic gliomas from the optic nerve, and chiasm, where you need to do a decompression at least.
Yes, sir.
Because of the muscle. Is it described exophatic?
Yes, sir. Yes, sir. In certain studies, they have described debulking. If that is exophatic mass, can be debulked, sir. It is also one of the advised procedures, sir.
Okay.
Thank you.
Dr. Suresh, again a question for you. It is a nice presentation. And how often you see an optico-chiasmatic hypothalamic glioma? Mostly,
it's very rare. Very rarely.
We come across quite often. That's why. Okay.
Thank you. So only present this case, sir, because last week I had opposite of sporadic optic pathology glioma. So only I want to present this presentation, sir.
Sir, TT Rajan, sir, you tell your answer, sir.
Just a minute. So it's called stealth modification of bicoronal incision. The name of the incision is called stealth modification of bicoronal incision, and it's just not cosmetic. Even stencil strength-wise, it's a very good incision, because once you put a linear incision and you expand the skull volume, there'll be a lot of pressure on the incision, linear pressure, and there'll be uniform pressure. So what will happen is scar will become very ugly, and there'll be a 1 or 2 centimeter strip of band on the head where the hair will not grow. So that's and the wound breakdown is also more common with the linear, like our traditional incision we use. Once you use the stealth modification, the tensile strength distribution is disrupted. You don't have a uniform tensile strength. It's zigzag, so it will wound dehiscence chances are significantly less. So it's much stronger incision, and cosmetically also the hair growth will be much better, and you'll not see the incision when the child is growing up. So this is the advantage of that. A lot of studies, and like what we told, none of our neurosurgery journals describe this. Most of this is from the plastic surgery and OMFS journal.
Okay, sir. Now we will put the last question, fourth question. What are the first in chemotherapeutic agents? Oh, in this answer itself given. This question is getting cancelled actually.
Shall I close that?
No, that question answer is there.
Oh, okay,
so
sir.
we cannot.
Okay, sir.
You should have cancelled the answer.
Okay,
you have
sir.
put the answer also.
Okay, sir.
You have put the answer also. That's
Shall I
why.
close it, sir?
No, other question we will do. The last question is, what are the histological characteristics of pilocytic astrocytoma?
Sorry, sir. Photo sir.
What are the histological characteristics of pilocytic astrocytomas?
ಇಲ್ಲ ಮುಡಿದಿದೆ ಸರ್ ಶೋರ್ ಸರ್ ಮುಡಿச்சிட்டே சார் வேற
ஆபீஸ் ரூம் தான கொடுத்துருக்கீங்க சார் அது நீங்க கீழே போயிட்டு உங்களுக்கு டேபிள் எல்லாமே இருக்கு
Rajesh, meanwhile, can I make a comment?
Yes, sir.
I want to thank, you, for taking all the pains in arranging such wonderful set of lectures. I think starting from Balamurali, who had all are, gems of presentations. Balamurali's minimally invasive technique for intradural tumors. Then Dr. Vishwanathan's presentation on functional neurosurgery and craniosynostosis by Rajan, and Suresh Babu's optic pathway glioma. All have been very high standard, and I must thank you for unearthing such a beautiful talent from among our people. Thank you very much.
Yes, sir. Yes, sir. Now we will tell the winners also, and then we will. Now we are going to have the endoscopic workshop. Dr. Kodishwaran is there?
Yes, sir. Yes, sir.
Yes, sir. You can talk.
Sir, I welcome
You invite all of you.
I welcome all of you to join us on the upcoming TANS and other association affiliated cadaveric workshop in Government Kilpauk Medical College on 30th December morning 8 to 2. First 1 hour we'll have 3 lectures by 3 faculties from various places, and followed by inaugural function of Neurosurgery Academy at KMC, and also a special back pain clinic for Tamil Nadu police personnel inaugurated by DGP of Tamil Nadu. Followed by we'll have 4 hours dissection session with 6 stations. We have taken 30 students from all over India. Followed by we have lunch, and we'll disperse at 2 o'clock. So I welcome all senior faculties to KMC cadaveric workshop to guide us how to do this further. And I would like all members of TANS, CNA and other societies, and also all neurosurgeons from Tamil Nadu for this workshop, and come and join us. And we are expecting you on 30th Friday morning from 8 to 2. Thank you, sir. And also we got 2 credit points from Tamil Nadu Medical Council for this workshop.
Now we will have the winners of this quiz. For the first question, how to access the intradural intramedullary tumors with a unilateral approach? The answer is through the dorsolateral sulcus of the unilateral tumors, and the winner is Nagavishnu. Nagavishnu is there?
Yes, sir.
You are from which college?
Tirunelveli Medical College.
Tirunelveli Medical College. Congratulations. Congratulations for this. I think you are winning all the third meeting also, no? I think.
Yes,
third time you are winning, I think, no?
Yes, sir.
Congratulations.
Yes, sir.
So you are coming for endoscopic workshop?
Yes, sir. We have to come.
Welcome, welcome. Now for the second question, the deep brain stimulation is useful for the following indications. It is the all of the above is the answer: dystonia, essential tremor, obsessive compulsive disorder. And the winner is Christian Bernard. Christian Bernard is there?
Yes, sir. I'm there, sir.
Yes, come on. You are from?
Sir, from Stanley Medical College, Chennai, sir.
Okay, very nice, very nice. Congratulations. And for the third question, actually no one has answered correctly. Everyone has given the answer as cosmetic, and so there is no takers. And for the fourth question, what are the first line chemotherapeutic agents for the that is the thing. And the last question we have asked was what are the fibers? And the answer is the Rosenthal fibers, and the answer is given by Christian Bernard. So Christian Bernard wins the fourth question also. So Christian Bernard has won two answers, and Nagavishnu has won the other prize. So congratulations all the winners, and I request I invite all of you to come to the endoscopic workshop, which is to be held on Friday morning. Make it available and try to come and join the program. So now it's time for vote of thanks. It is by Dr. Kodishwaran sir.
I would like to thank everyone, because each and every CME, our standard of